So we're at 2 minutes past, which is I'm reliably informed by my mentor, Professor Patrick Chinnery, is a Chinnery unit of time, which is Zoom politeness. So welcome everyone to the Global Brain Health Clinical Exchange platform. Thanks to all of you joining us from Kenya, Moldova, the UK, Mexico, South Africa. Just really, really wonderful. So many of you will know me already, but my name is Dr. Benedict Michael. I'm Associate Professor of Neurological and Infectious Diseases in the UK. I'm delighted today to be joined on the panel by Dr. Viraj Barambi, a neurologist, also in the UK, by Dr. Divya Doha, who is an infectious diseases specialist, an associate professor who's joining us from the Christian Medical College, Christian Medical College in Vellore in Tamil Nadu in India. And also by Professor Kiran Thacker, who's Associate Professor of Neurological Infectious Diseases at Columbia University in New York in the US. Firstly, briefly, I'd like to thank the WHO and the Policy Exchange Network who funded this and make this all possible, and for the WHO's ongoing support on us, really helping to engage globally, and not just on COVID, but really using COVID as a catalyst to encourage us in the neurological infectious diseases community to remember that we're all floating on a rock in space, and things all work better when we work together collaboratively around the world. And it's great to get people's insights and experience. So the format of today will be a 20-30 minute presentation, and then we'll have time for some discussion as well. And it would be great to have your input. So please do have fingers on the button when it comes to the polls, because we'd love to hear your opinions and experience. But also if there are questions and comments in the chat, that would be great also. And Viraj is going to help me manage that. So presenting today is Dr. Bhagteshwar Singh. He's an infectious disease specialist and also a PhD fellow. He's originally from the UK, but he splits his time now, as we will hear, between India, Brazil, and Malawi, working on improving the diagnosis of brain infections. And he's in Blantyre in Malawi now, where he's joining us, and we're hoping the internet connection is going to hold up. It's been okay so far, but we won't count our chickens. So without further ado, Bhagteshwar, over to you.
Thank you, Ben, and thanks everyone for joining. Just put this in slideshow mode. I hope everyone can see my slides. A thumbs up would be good. Great, thank you, Viraj. Yes, hi from Malawi. So I'm going to talk through some challenges and priority issues in the area of neurological infectious diseases, focusing on brain infections and how to improve diagnosis and management. As Ben mentioned, I've got a clinical infectious disease background, and for the last few years I've been based out of the University of Liverpool, but mostly in these other countries that Ben mentioned, working on the brain infections global program, which is, I guess, very much aligned to what we're talking about today. I'm going to start with a case. This is, and I'm going to try and keep this simple. I know not everyone on the call is a clinician or necessarily a specialist. So sorry, neurologists, there won't be lots of interesting neurological signs, but bear with me. So you're presented with a 47-year-old man who's usually healthy with no past medical history. He presents with 2 days of fever and headache, and today he's become quite disorientated, not really aware of his surroundings and people around him as he normally would be, and he's become quite drowsy in the last several hours. On examination, the most remarkable thing, beyond him being a little confused and drowsy with that Glasgow Coma score of 13, is marked rigidity of the neck muscles. So this is poll number 1. And yes, great, the poll is on the screen. So what should be done for this man in front of you in the first 24 hours of his admission to your hospital? And I should say this is going to have quite a hospital viewpoint to it overall. So please try and put yourself in that position if that's not where you're usually based. So number one, should you arrange brain imaging or administer intravenous ceftriaxone or perform a lumbar puncture or arrange some rapid blood tests for common pathogens that are seen in your setting, or all of the above? So please select one of these. Great, thank you. So it looks like everyone wants to do everything, which is a nice outcome here, I guess. I'm not going to talk much about this right now, but I mean, I think it's clear that 80%-ish want to do all of these things in the first 24 hours. So poll number 2, is which of these should be done first? So is it, again, brain imaging, ceftriaxone, lumbar puncture, rapid tests for specific pathogens, or anything that's not been listed above? Hopefully this is a little bit more challenging than poll number 1. Great. I'm not sure I'm supposed to ask for the closing of the poll, but yeah, great. Thank you. I'm sure there's a specific time on it. Okay, lovely. So actually, thankfully, I didn't miss the points with the first 4, and there's not a lot of people saying I would do something else. It looks like performing a lumbar puncture immediately is the most popular answer, after which very closely in second place is ceftriaxone. And then brain imaging, and then rapid tests for specific pathogens. So that's great. We'll move on then from here. So let's just examine these in a bit more detail, or kind of go into maybe the pros and cons of each of these. As you can see, there was quite a split between at least the top 3 in terms of what people would like. So firstly, arranging brain imaging. The chair published this several years ago regarding the effect of delay in doing a lumbar puncture after giving antibiotics, and the effect that has on culture positivity. And I think, the reason I put this up on here straight away is just that doing your imaging, most people would tend to then give some sort of treatment for what might be a life-threatening condition, in this case meningitis, and that then would automatically delay your lumbar puncture while waiting for imaging. In some places, imaging is very quickly available, and others not so. And in the UK, we actually struggle to get immediate brain imaging, and so that does lead to delays then in lumbar puncture. And so this, hopefully you can see, shows an increase in the proportion of patients within these bars as time goes on from antibiotic to lumbar puncture that are lighter gray, which reflect those with a negative culture. So you've got an increasingly negative culture, shall we say, as you increase the delay between antibiotic and lumbar puncture, and imaging comes in between those two quite often. Accordingly, most guidelines that advise on brain infection management will list some indications for neuroimaging before lumbar puncture in order to try and make lumbar puncture as early as possible in the patient interaction. And these are just some examples here from the UK and from Canada. And some of you might have seen this study from a few years ago in Clinical Infectious Diseases, which examined whether patients are managed according to the IDSA guidelines in the US in terms of the indications for CT scan prior to lumbar puncture. And I think the take homes here, maybe this isn't so great the way I've put this together, but the majority did not have an indication for a CT scan, and yet the vast majority, a larger majority, did have a CT scan before lumbar puncture. I think the interesting kind of results from there when examined by independent assessors was that there were abnormalities when there was an indication for imaging, much more commonly than when there was no indication. And if you then look at major intracranial findings, they were seen very rarely, and that too in those who have an indication for brain imaging. And I guess the other issue is that there isn't a brain scanner available everywhere, sorry. And so an example is here in Malawi, the hospitals that we're working in do not have a functioning CT scanner either at all or every day of the year. And that applies also to a hospital that we're working in Brazil. So you might then have to transfer this patient in order to get that brain scan. So should this patient be transferred to another hospital for a brain scan? And I guess the implication here is before lumbar puncture, but I guess at all with what you're presented with just now. Okay, thank you. And I guess this is one of those things, isn't it? Do you need a consult by specialty X? Well, they're in another hospital, so maybe not. This happens across medical practice quite widely, and so you can see that not so many people would actually transfer this person to another hospital if that's what's required to get that scan. Although I acknowledge that most of you didn't say this should be the first thing to be done for this patient. So coming back to poll 2, which we'll come back to repeatedly, sorry for the very samey slide, but this is now administering ceftriaxone. So here's this figure again. Ben in particular, I think, will be sick of this soon, if the rest of you aren't. But again, giving your ceftriaxone up front might save that person's life, but it might also mean that in a few days you don't know what's causing what looks like meningitis. So this is really just to remind us of that, and kind of here as well. This is a schematic, I guess, by me synthesizing what we know from the literature, and also as I said at the bottom, these axes don't have numbers on them intentionally. They're not to scale, and this is just how I think about this in terms of what we know from studies previously. Already we kind of have this feel in the last several years of maybe PCRs for the typical pyogenic meningitis bacteria, strep pneumoniae, and meningococcus and Haemophilus. PCRs are probably a bit more sensitive than culture, even when you haven't had antibiotics previously, and that might be modified by the type of culture service you have available. And gram stain is probably a little less sensitive because and maybe increasingly so with earlier presentations because the bacterial load might not be as high. Maybe you can ignore the turnaround time thing in the bottom, but that's I have clearly repurposed this slide from another point I was trying to make in a previous presentation, but I think it works well here, that after your antibiotic pretreatment, the sensitivity of all of these probably goes down, and maybe most so in relative terms for culture. And so where you don't have PCR available, that might be even more important. Another marker, if you'd like, of pyogenic meningitis, CSF lactate, which has shown promise, seems to work pretty well in this meta-analysis of 33 studies. Sorry to not put the citation up here, but that sensitivity, especially specificity is relatively preserved, but the sensitivity falls greatly to less than 50% if in patients who have had antibiotic pretreatment. So yes, let's save the life of the person in front of us, but try and arrange it so that the cost is not knowing what to do in a couple of days. And I think the other issue is, are we giving the right treatment? So, did some of you not say intravenous ceftriaxone because you were thinking of something else, or actually did you think yes and something else? And so poll 4, which other drug would you consider in this patient? And maybe just think about, again, your current setting and what would be relevant there. So acyclovir, doxycycline, amikacin, azithromycin, or anti-TB therapy. And I should say, I don't think I said earlier, there's no right answer. Please just go for it. And obviously, this is all anonymous. Okay, acyclovir, right. Yes, interesting. So we've debated this quite a lot in the Brain Infections Global Group recently, actually, and what would kind of constitute suspected encephalitis. And obviously, in many settings, the most common treatable cause of encephalitis is herpes simplex virus, and maybe varicella zoster virus features there as well. And though there's controversy over whether acyclovir would help in a meningitis due to especially herpes simplex, that controversy is still alive. Although I think it's reasonably fair to say we don't think it necessarily saves lives in that context. But for varicella zoster, I think a lot of people would treat even if there's a meningitis without convincing encephalitis. But also the reason I chose these other drugs was because there are different pathogens in different settings, and actually seeming as though someone has encephalopathy and maybe encephalitis in this context, along with meningeal irritation, or whether this is a bad meningitis causing encephalopathy, you may want to cover for bugs that also infect the brain parenchyma. And so we've, within the Brain Infections Global Program, we've conducted a systematic review, which you hopefully will see in print very soon, which kind of highlights this issue of, firstly, a lot of these bugs that seem to predominate in studies in the 3 countries that we're working in are treatable, but also I've just highlighted those that might be treatable in this context, but not covered by ceftriaxone. And I think, unfortunately, I missed out the big herpes simplex at the top there accidentally, but the rest, I think, are in line with that. So I'm assuming that those who said doxycycline were probably from places that see a lot of Orientia susukumushi or scrub typhus, the disease it causes. So let's move on. And I should also say I'm hoping not to resolve or teach anything in this, and this is to kind of stimulate thought and then discussion. And when we open the session up to more wide discussion, and obviously in the chats, hopefully there'll be more kind of resolution to some of these things, perhaps. So in terms of performing lumbar puncture as the first step, so I think what I've preached to you so far, maybe with that figure from that study, is that we need to do a lumbar puncture as soon as possible, and I think that was what the majority said, or sorry, it was the most popular answer. So we'll just move straight into the next poll then. I think we all understand the importance of lumbar punctures, but in terms of what's relevant in your setting, what is the biggest priority for improving lumbar punctures where you are? And the options are consumables, both in terms of availability and appropriateness, the volumes you obtain of CSF, of cerebrospinal fluid, storage conditions for that CSF, transport to the laboratory, and which tests are requested. Some of you might be thinking, where is the all of the above option? We'll just wait for that poll to close. Okay, results. So requesting the correct tests is the most popular option here, but quite a significant chunk also said consumables and the volume of CSF. Okay, great. And fewer of you said storage conditions and transport to the laboratory, although I'm sure those of you who didn't say those things don't think that they're not priorities. I guess these others are just higher priority. Okay, thank you. Nice to still have a reasonably even split between 3 of them. This is something that that I actually will come back to in terms of how our brain infections global program is looking at this. But this again by Dr. Michael and colleagues. This was a lumbar puncture pack, and guidance for it is on screen, put together to try and improve, I guess, all of these things. And you can see elements here of which, so providing the right containers all in one place, and pointing out which ones there are, and giving some idea of an order of draw in collaboration with kind of the laboratories who dictated that, what volumes should be taken in each of these containers, which tests should be requested and where they should go, and a bit about transport, how they should be transported as well. And this is something that we're hoping might work in other settings as well, and we'll hopefully report back on that soon. Rapid tests for specific pathogens. So next poll. Which of these pathogens is most likely to cause someone to present with suspected brain infection in your setting? So the options are Plasmodium falciparum, malaria, Orientia susugumushi, scrub typhus, Cryptococcus neoformans, Mycobacterium tuberculosis, and herpes simplex virus. So maybe just step back from this specific case and just think about the patients you see in your practice or are likely to see in your setting. Great, we'll just wait for the poll to close. Okay, thank you. So the most popular answer here is TB, and then herpes simplex virus, and then Plasmodium falciparum, malaria, Cryptococcus after that, and then Orientia. Okay, great. So I guess looking at these one by one, number 4 and number 5 were the most popular answers, but unfortunately we don't have rapid blood tests available for these that perform well as far as kind of the literature goes so far, whereas the top 3 do. And I'm sure whichever you're setting, you might be thinking about the top 3 in some patients, whether they might be returning travelers or those with immunosuppression or with specific clinical features. And so here again, kind of just going back to this figure from our systematic review of etiology in these 3 countries, here are some pathogens for which we do have point of care rapid tests available on blood, and obviously the most kind of widely used globally probably are for malaria and for Cryptococcus. There are quite a few now for Orientia susugumushi, which we'll come back to. And I believe there are some for Japanese encephalitis virus, but they aren't so widely used at the moment. You could argue that the latex antigen tests that are often used on cerebrospinal fluid could be used directly on blood, but actually that is a practice that I think is now not so prevalent, and therefore I haven't put a box around the kind of the classical pyogenic meningitis bacteria. So just a few words on rapid kits for blood. Most of these will use a lateral flow or ICT method, which I think world over many lay people are now used to, or those maybe who aren't trying to see if they're pregnant, who which is where kind of we would have seen this previously. I think all sections of the population now have used these or learnt about them in the context of COVID, and therefore they are pretty easy to use and quite desirable. If they work well in a broad range of settings, especially those without 24-hour or on-site lab facilities for these tests. Some of them will detect antigens, some detect antibody, and mostly in this context, I guess we'd be thinking about those that detect IgM to look for as a marker of acute infection. Some look for both. in a combined way, and dengue is one of the pathogens that can be looked at in terms of the IgM, IgG, and the NS1 antigen all on one card. They're pretty widely used, as I mentioned, for malaria and cryptococcus and dengue, and increasingly chikungunya and scrub typhus. But there are concerns about how sensitive they are and how well different kits or brands perform. Here's one example. So scrub typhus, which we see a lot of in India. The gold standard for diagnosis is quite difficult to access in various places. And so there has been quite wide uptake in point of care testing. This meta-analysis of I think about 30 studies showed that the pooled sensitivity of the tests that are available is only 66%, where the specificity is higher at 92%. And one other concern that was raised by this was that if you look at different kits, they vary quite substantially in terms of their sensitivity versus specificity, and therefore, the way they will perform in various settings. And so I guess my take home from this is look at the kit you're intending to use, look at studies that are reporting use of this, and just interrogate also which population they're being used in and whether that's relevant for the patient in front of you, or maybe more so at kind of a departmental or hospital or lab level. So they sound like game changers, but are they really? And I think we've had enough of the discussion about that in context of COVID previously as well, for that to be recent in your minds. So the other issue with blood tests, versus that lumbar puncture that we knew was of paramount importance and wanted to do some CSF testing, is that these, especially kind of the IgM antibody that we're looking for in a lot of these tests, is famous for cross-reactivity with various antibodies that might be produced by our own bodies against pathogens, but also things like rheumatoid factor. And so there's a concern about then incidental detection of whether it's antibody or antigen, and that might actually just reflect asymptomatic infection or a co-infection with active disease that's systemic and not necessarily the cause for the brain infection syndrome you're seeing in front of you. And so here's one example from Malawi of a study done by the members of the brain infections group, as well as here in Malawi and other groups. And I think the take home for me and for a lot of us, and I guess this I think is now kind of practice within pediatrics, especially here, is that just because you see malaria parasitemia on a rapid test being positive for antigen. So this actually, sorry, in this case, they did a slide, microscopy for falciparum, but this might be even more of a problem with these rapid antigen tests, that many of these patients who also then had a workup for viral infections had a coincidental viral infection. So if you look at this number 45 and you look at the 163 with falciparum parasitemia, that's coming up to a third of patients with that positive malaria test also have another pathogen detected when you look a bit more widely. And there are similar studies out there that, and I think, we've known for a long time that bacterial meningitis and falciparum parasitemia often coexist. So what else? Not many people said that that we should do something else. But I mean, here, let's just step back a little further and say, in your setting, what is the biggest priority for improving diagnosis and management of those with suspected brain infections of these five? So firstly, improve recognition, and that could be, just seeing if someone might have a brain infection or individual brain infection syndromes. Secondly, increased availability of tests in your hospital lab, or in your hospital on the clinical side, if maybe there's scope for rapid tests. And then the next one, I guess, is, actually moving that laboratory testing that might be existent already to the point of care. Fourthly, improving lumbar punctures. You already know I'm biased towards that relatively, and also how you handle the CSF before it gets to the laboratory. And then finally, increasing the availability of brain imaging. I do like these polls. They give me a chance to have a sip of water and just pause. Sorry, but also more importantly, we find out what people are thinking. And right, so this is interesting. Improved recognition of brain infection syndromes is the most popular choice. There's a relatively even split then for numbers 2, 3, and 4. And those of you who want to do the brain imaging first either have scanners in your hospital, or I've convinced you that the other things are more important. You probably have scanners in your hospital, don't you? Okay, I guess, so there's a lot around diagnostics in 2, 3, and 4. And maybe on the whole, we're looking at diagnostics in terms of percentages. That's about 60% of the total. But really the most popular choice was improved recognition. Okay, thank you. So I'm just going to, in the final 3 slides, I think, just mention, a few more than 3 slides, but it hopefully will feel like 3 slides, mention a bit about the Brain Infections Global Program. So we're based in Brazil, India, and Malawi, and the UK. The program involves various themes which look at different aspects of brain infections and how to tackle diagnosis and management in hopefully a sustainable way that then feeds into policy. And we've got patient and public involvement through a dedicated panel across all of these themes. The main focus of the program is an intervention study, and there's a baseline phase which looks at current practice and what challenges there are in achieving optimal practice and what capacity there is to improve. And that we looked at journeys of patients and their CSF samples through the hospital system up to getting a diagnosis or up to discharge, and then working out why a diagnosis wasn't made. As well as some laboratory capacity assessments against what was devised as kind of an ideal brain infection lab. And we've also looked at quantitative data across various hospitals in these 3 countries. We're currently in the process of developing and implementing an intervention, and we've been I mean, I was a little late to this call earlier because we actually spoke to someone in the Ministry of Health in Malawi about the study and about the intervention, and so we're throughout the countries working closely with policymakers, as well as obviously most importantly clinicians and laboratorists on the ground to make sure what we're doing is feasible and hopefully sustainable. And obviously we're trying to work out what impact this has, both in terms of the primary outcome of making a diagnosis and other important secondary outcomes, but also the cost of the intervention. And what we're really kind of gearing towards is hopefully through doing this in various different types of hospital in each of these 3 countries, which are already quite different from each other in terms of epidemiology and healthcare context, that we might be able to put together a standard care package or a toolkit for patients presenting to a wide range of hospitals globally. The intervention is structured like this. So this might remind you of the building blocks of the WHO health systems approach. We kind of condensed that a little, but also took out various domains within these various components within these overall domains that we thought might be helpful to think about what could be done about what we're seeing. And as I mentioned earlier, we're working closely with key stakeholders to make sure the intervention is relevant and feasible and sustainable. And I'm just going to flick through very briefly some very preliminary things that we're putting in place. So we're putting in clinical algorithms, adults and children in our Vellore Center in India. And this is an overall algorithm for patients in Brazil, as you can see in Portuguese. And then the lumbar puncture pack guidance that I showed earlier, we're doing things like this. This is an example from our Bangalore Center in India and what is happening so far. So changing existing lumbar puncture equipment and consumables, as well as providing guidance where there wasn't in terms of how to use them and how to handle CSF. And then diagnostic pathogen panels. And this is an example of just the workflow of how things work in Brazil at the moment. So someone comes in and has a separate sample sent for augmented testing. That testing is done. If those tests and other hospital tests are negative, we then move on to the next step, etc. Then this is just kind of showing you the broad range of things that we're putting in place in each center, but not in a lot of detail. And just some pictures on the right-hand side from a workshop we had with a wide range of stakeholders, which also involved some training for key clinicians. And at the bottom here, a meeting with the state health secretariat in Pernambuco in Brazil, where we work, to try and make sure some of these things are embedded within the wider system. I'm just going to, so I think I've run over a little bit, but I'm going to stop here and just say thank you to the Brain Infections Global team as a whole, and in particular the chief investigator and the principal investigators, and I haven't named them, but the coordinators and fellows and other study staff in each of our centers. Thank you.
Super, thank you, Bhagteshwar. That was one wonderful romp through the complexities of managing these cases in different sorts of settings. So that was really excellent. Thank you. So I'd like to ask to invite Viraj Barambi, Kiran Thacker, and Divya Diyahar to pop their cameras on if they don't mind, and unmute if you can. And for those of you joining us, if you've got some questions or comments or reflections from your experience, do please pop those in the chat. We've had a couple already. Viraj is going to keep an eye on them, but I've managed to pick up a couple that have come through whilst you were talking, Bhagteshwar. So I'll put them to you first, and then it'd be great to get Kiran and Divya's thoughts on it and the wider thoughts of the team on the call. Alistair, who's joining us from South Africa, raises 2 points. One, which is about the main problem there with lumbar punctures, is personnel, adequately trained personnel, I assume, and also personnel in numbers and out of hours personnel and those sorts of things. And then another question, which is a bit more contentious. So I'll let you have a go at the personnel one first. Is that something you're looking at in Brain Infections Global, or is that proving to be a major problem?
Yeah, I think personnel is a problem everywhere. When we're talking about feasible and sustainable intervention components, going to policymakers and saying we need more people on the ground is very difficult. But in terms of training, yes, we're making sure that we're doing some clinical training in every hospital, and that has included lumbar puncture specific training, which we've done in India, and we're going to do in Malawi soon as well. And some of it is not just the procedure itself, but also we've identified some needs in terms of consent and the delays incurred. I think Kiran's done a lot of work on this, as well as you, Ben, in terms of, I guess, empowering clinicians to take consent in a way that puts forward the benefits and the risks in a balanced way, that then people don't say, "Oh, I don't want a needle in my back. Thank you very much," or "I knew someone who had this and then died," which are kind of common barriers, I think.
Kiran, you may want to speak to that given that you've done a lot of work in this space.
And Binya Mayeli, who I'm not sure if he's on this call, but he is a wonderful neurologist in Ethiopia, and he's really interested in this topic. And I agree with everything that Bhagteshwar was saying in terms of, I mean, it's a complex issue. I think there's personnel related challenges in terms of training and comfort with the procedure itself. There's issues on the side of just availability of lumbar puncture kits and, you know, the ability to have sterile samples and trusting your laboratory that when you send them labs, the results are not just going to be like 0 whites for everybody, and it's actually going to be kind of clinically useful, which we've all heard a lot. And then there's the side of the patients who I think, you know, especially around endemic areas and high crypto burden regions where we're doing many lumbar punctures as part of routine management, there's this sense of, okay, the LP could be dangerous in and of itself to you know, lead to, you know, morbidity and mortality, and it's the lumbar puncture rather than it being a treatment that's so fundamental and necessary, and that gets very intertwined. And I think really dealing with the complexity of this is something that that we need to do holistically around, like the centers, like you were talking about. It was just a great presentation, so much work you're doing. And yeah, I think those are, I mean, just some of the issues with LPs, but I think we're really interested in training. How do you train people on the ground? I mean, we do a lot locally with like things like simulation setting that can be really challenging.
Divya, is this a problem in your setting as well, or what ways have you gone about tackling it if it is?
Yeah, so in India, like you see a variety and a varied, like something like CMC Belor, which is like a tertiary care center. So we don't have any problems at that level, but then there are centers which are secondary or primary level care, like basically like an outreach clinic that we see in CMC as part of our network, and also places where there are rural areas where we don't have personnel. And so, like Bhagteshwar said, that training is important, and training plays an important role where we because lumbar puncture is a very important test, and without that, you know, we will not have either epidemiology or treatment per se, and treating empirically to these patients is not really correct as what we have seen. And since India is a vast country, we also see in different places in India itself the epidemiology changes and the etiological agent change. So it's very important to kind of, you know, lay stress on the lumbar puncture. And so we have our group in the BI Global that we are doing, and otherwise also. So as the junior doctors come or technicians come, we have this simulation and things which are there at the beginning of their medical school. I mean, as they finish their medical school and going on to the residency program, that we train people, as well as in the peripheries that we train. So it's one of the important things that I consider it's important to do a training of the personnel.
Yeah, no, I agree with everything you said. I mean, I think one of the things I've always thought with training, particularly when it comes to lumbar punctures, is just in time for you to get the junior doctor confident in taking consent and doing it, they've rotated on to another specialty where they're not doing lumbar punctures very often, or they get the promotion to the next grade. And I've always wondered whether there's given what stroke nurses have done for advancing the care of stroke patients, whether acute neurology nurses embedded within the acute medical unit, who are there all the time for many years on end, being trained in techniques like lumbar puncture. It might be one of these ways of solving the kind of personnel and the skills shortage, but it's complex. Erich Schmutzhardt, who's a professor from Austria, has an excellent question. Erich, do you want to speak to it, or would you like me to outline it? Okay, I'll outline it for you, Eric. Thank you. So your algorithms are beautiful, Bhagteshwar, and I'm sure they took you an awful lot of work to get them right. Eric has a much more simple solution. Number one, you do a blood culture. As soon as you've got the blood culture, you start them on IV ceftriaxone and do a lumbar puncture simultaneously. And as soon as you've done the LP, if the CSF is not turbid and the CSF lactate isn't raised, you start them on acyclovir. It seems very pragmatic and very sensible. Wouldn't work in all settings, but I know Eric has worked a lot in some parts of sub-Saharan Africa, such as Tanzania. So what's the panel's opinion on this very pragmatic, streamlined approach to acute management? Bhagteshwar.
So before the senior experts speak from the panel, I should just say these aren't my algorithms; they're our algorithms. We very much kind of built them with investigators and clinicians within each of the hospitals. But yeah, I think I was actually just typing response to this. I think Viraj, thanks for responding to the comment about blood cultures. I agree, blood cultures are really important, and some bacterial meningitis can be diagnosed that way, especially, I guess, pneumococcus, maybe meningococcus, especially if there's some degree of sepsis. And I think if lumbar puncture is delayed or for whatever reason, it might be a good way to reduce that gap between doing a diagnostic test and having given antibiotics. I think regarding the rest of the algorithm, I mean, if only I could have suggested a 1, 2, 3, and that could have just worked. I think Dr. Divya, you were involved in a lot of this kind of for the Vellore Center, and I think some aspects of that served as a bit of a blueprint for some of the other centers as well. So maybe I'll pass this on to you if you don't mind, in terms of how this might work in India.
So yeah, thanks, Bhag, for that. What we see is a very small percentage of our patients who present with brain infections are usually pneumococcal infection, and the positivity of blood cultures is also not 100% because of many reasons. One could be the patient would have probably received an antibiotic before coming, or would have been treated elsewhere with so something like a drug defined or a drug refined disease. Is that what we see? So that is one of the reasons. Then a small percentage of people. Then we have many diseases which come with seasonal variations. So like Bhag had presented in his slide, we have a large percentage of patients presenting with scrub typhus or Oranchius sugamushi that we see commonly, and there are pockets of these infections which are prevalent in areas in India. So when we say like I definitely agree with Professor Eric, but there are a couple of just my thoughts is that only doing a lumbar puncture and giving ceftriaxone may not we need to know what are the basic etiology, because it varies from season to season, it varies from places to places. So whatever we are doing in the southern part of India may not necessarily happen in the northern part, and then we miss certain things. So that is one thing. CSF lactate is so it's not a test that is rapidly available, so we may not get it in. So the turnaround time for CSF lactate may not be so quick that we can depend on that and probably go on to thinking of a viral encephalitis and start acyclovir. So that is one of the things which is common. And then while we were making the algorithms in our center, there was so much of difference between adult and pediatrics as well, which is so very important. And Bhag would agree with me that we never came to a conclusion. The ED people may differ from the internal medicine and infectious diseases. So kind of bringing everybody together on a common platform was really difficult. So those are some of the concerns when we kind of put a narrow algorithm. So yeah, thank you.
Yes, thank you. And yeah, getting neurologists and infectious disease physicians to agree is a challenge. It's been my challenge for the last decade and a half. I should give Professor Schmutzhard the right of reply, I think. Eric, your hand is up. Would you like to speak to that?
One additional point I wanted to make is with this case, Glasgow Coma Scale 13, you can do lumbar puncture immediately without any MRI or CT scan or whatever. First thing, the 3 points I have said, take something we have checked that both in Austria and in Tanzania. I don't know, several dozen times, 30, 40 times. It doesn't take longer than 20, 25 minutes. And you are always well below the 1 hour, which should not be exceeded, starting the correct, the appropriate antimicrobial agent like antibiotic. And in most cases, it will be ceftriaxone. In southern Tanzania, we don't have ceftriaxone, so we give simple penicillin. Because we don't have listeria either. And the last point I wanted to make, in case of a bacterial meningitis, and this is a older man or a woman, diabetic or whatever, then you should not forget listeria all over the patient. So
you're breaking up ever so slightly, Eric, but I think we got the key messages there. Thank you. And there was the importance of listeria in older people. Guidance varies between the age of 50 or 60 and varies by geography as well, and exposure. But that's an important point for thinking about amoxicillin and other listeria effective meds. Alistair's asked a question, but it's a big one. It's about, you're comparing the point of care tests sensitivity and specificity to the gold standard. What's the problem with the gold standard? You know, maybe it's the gold standard we ought to be addressing and getting that right.
I agree. And I think a lot of studies now use a composite reference standard in order to get around this issue, and using multiple potential reference standards or gold standards and combining them into this composite might be helpful in terms of acknowledging the individual inadequacy, I guess, of each of those. So I guess that's one option in terms of looking at these tests. I guess the other challenge is doing a study in the setting where a test is most needed versus what's available for that study in terms of resource. And that might mean that you can't get the gold standard, which might be very expensive. An example for scrub typhus or Orientis sugumushi, I guess, that we were talking about earlier, might be using PCR or IFA are often kind of looked upon as gold standards, and then comparing a rapid test to those versus what's more available in most places might be an ELISA, and we know that ELISAs in general cause are imperfect reference standards. So yeah, it's a problem, but and I'm not sure there are loads of ways around it, but we're trying to do some of this, I guess.
I think you're right, isn't it? There is a core set of things people have to get right, like doing a lumbar puncture and the timing of the sample and getting it to the lab before we can move on to the bigger things. One last question I think we've probably got time for. This might be one for Divya or for Kieran, perhaps. Could you comment on serologic cross-reactivity between dengue and COVID and malaria and COVID? And I suppose, dengue and JE is actually the other thing we think about a lot, but sorry, I'll hand that to you guys.
Divya, you go ahead. You're in an endemic area.
Yeah, so that's a major problem when we talk about serology, and then we do not know what to treat. So what we do to our junior doctors is basically, and we've had studies in Velo where we kind of see what's the most common at that point in time. when the patient is presenting, maybe say a seasonal variation of infections, or age variation and things like that. So so more so like a syndromic approach. But yes, patients who come in something like an acute undifferentiated fever with encephalitis or encephalopathy, we always land up into a problem. So a pretest probability helps in those situations when we have to do this serology. I mean, when we have to depend on only serological test and there is no PCR available for that. But yes, one possibility is that you can go for the rapid test in the beginning and then wait for either PCR or culture facility to come. But that does not happen in viral illnesses. So that is one of the drawback. And then yes, with dengue and leptospirosis, or not malaria so much, but yes, these are the two things that we've seen a lot of cross reactivity. But again, I think we depend more on syndromic diagnosis along with the seasons that they present with. So those are the things that help in this situation. But there are a number of papers who've documented kind of cross reactivity, and that's always a problem, especially now we are seeing with EBV and things like that. So you have to basically look at the host, what the host is, and then you try and match the disease and look at your pretest probability.
Yes, yeah, that's great. Thank you. So I'll draw it to a close just by thanking Dr. Bhagteshwar Singh for a great presentation, Professor Divya Diyahar, Professor Kiran Thacker for joining the panel, Dr. Viraj Barambi for coordinating this along with the Global Health Network. The next one of these is on the 24th of June. It is again free, and it'll be on critical care, neurology and neurological infectious diseases, and it'll be led by Professor Sherry Chu from the US. And I think we should end on a wonderful high note. We're delighted to be joined often by many of our WHO colleagues. And we've got Nicoline Schiess here from the WHO, who many of you may have seen in the chat, has just informed us that the World Health Assembly has just formally adopted the Global Action Plan on Epilepsy and Neurological Disorders, which is a huge, huge landmark achievement and really advances neurological care globally for these crucially important conditions like neurological infectious diseases and epilepsy. So huge congratulations to Nicoline and the whole WHO team and all those that have been involved in peripherally in helping support.
Exactly, a lot of people on this call who have been involved in this mammoth task. So thank you to everybody here. Very great day for us.
It's super achievement. It's wonderful. And thank you, Nicoline, to the WHO for your ongoing support of this endeavour, which I think is our largest attended so far with a wonderful global reach. So it's wonderful to see you all here. And I look forward to seeing you all again on the 24th of June to discuss the neurological and neuroinfection implications of critical care in high, medium and low income settings. Thank you all again for great questions and comments. Have a lovely weekend and we shall see you next month.